All right. Good afternoon, everyone. Welcome to another Department of Medicine Grand Rounds. Just as a reminder for folks, if you have questions for our presenters, feel free to put them in the chat, and we will pose those to our presenters at the end of their discussion. And so with that, I am very, very happy to introduce our discussants today, Dr. Anna Golob and Dr. Maryann Overland, who are both incredible teachers and a huge part of our residency program. So Dr. Golob is an assistant professor in the Division of General Internal Medicine, also an assistant program director for our internal medicine residency program, and associate program director for the Seattle VA Center of Excellence in Primary Care Education. And Dr. Overland is an assistant professor in the Division of General Internal Medicine, as well as associate program director for the primary care track for our internal medicine residency, and both are phenomenal primary care physicians at our Seattle VA. So I'm very excited to have them here to present updates in outpatient medicine for us today.
Thank you so much for that amazing introduction, Dr. Crum. And thank you for inviting us, Dr. Young, to speak to you and our colleagues today. We love practicing and talking about and teaching primary care medicine. This year, we read countless articles about primary care and general internal medicine. We will not be talking about COVID-19, but we've included 28 articles from and updates from 14 journals so that you don't have to read every single journal that comes out. I know we're all very busy people. And at the end of our slide set, we have an incomplete bibliography of other important articles that we read and really wanted to include, but we couldn't make our talk 3 hours long. So finally, we want to take a moment here to tell you how much we admire our Department of Medicine colleagues. We really think that you are all such heroes in clinical care, in teaching, and in research. And we were just talking as we were getting ready for this about how much we miss all of you. We miss seeing you. We miss the hugs and the high fives and the in-person collaboration. So we're really looking forward to a time in the hopefully not too distant future when we get to all be in the same room again. We have a lot to cover today, so I will press on. We're going to start with hypertension. There are multiple different kinds of hypertension we're going to talk about today. We'll start with our case. You're seeing a 46-year-old woman who presents for a routine visit in primary care. Her blood pressures are mildly elevated. She said, "Doc, my pressures are always high when I come in here, but it's the parking. But I swear it's fine when I check it at Safeway." So what are your next steps in evaluating her for hypertension? You wonder, is this white coat hypertension? Is this something else? And what is the long-term cardiovascular risk of white coat hypertension? But before we go into our article, just want to comment that with the advent and uptake of ambulatory blood pressure monitoring and home blood pressure monitoring, we have all sorts of different sort of phenotypes of hypertensions now. We'll be talking about white coat hypertension, which is high office blood pressure and normal home blood pressure. And we'll be talking about masked hypertension, which is normal office blood pressure and high home blood pressure. But there are other things at play here as well. So this was published in about 15 months ago in the Annals, asking what is the long-term cardiovascular risk of isolated elevated office blood pressure. There's a meta-analysis of observational studies, including about 26,000 people with untreated white coat hypertension or treated white coat effect, which is people who have known hypertension, are on treatment, or normal at home, but are high in the clinic. And then about 40,000 people who are normotensive. And the outcomes were cardiovascular events, all-cause mortality, and cardiovascular mortality. The quick take on this one is that white coat hypertension actually does increase our risk of cardiovascular events, all-cause mortality, and cardiovascular mortality, but there is not a similar association with treated white coat effects. So those folks who are known to be hypertensive and just higher at home, higher in the office and normal at home. And the authors think that this is probably because people with white coat hypertension are likely sort of in that pre-hypertensive or elevated blood pressure range, more so than normotensive people. So we need to really think about white coat hypertension as a risk factor for cardiovascular disease. What about masked hypertension though? And how do we even know that people have masked hypertension? This is a group of people who have totally normal blood pressure in clinic, but are actually walking around hypertensive all the time in their daily lives. So, but we don't really know how those things impact cardiovascular events. So this is a systemic review and meta-analysis with 100,000 people, about 40,000 untreated, 55,000 treated, and then 10,000 they couldn't tell if they were treated or untreated. And this is a really kind of dense systematic review that looks into many, many different topics. But the one of interest that I want to highlight is the relative risk for major adverse cardiovascular events, which shows that people with masked hypertension have a relative risk of 2, and people with sustained hypertension have a relative risk in the 2 to 3 range. So masked hypertension is a cardiovascular risk as well. So that lends the question, how do we even find out if people have masked hypertension if they look totally fine to us in clinic? And the answer is out of office blood pressure monitoring. So we think that probably 1 in 3 patients who are normotensive in the office have masked hypertension or masked uncontrolled hypertension. So out of office blood pressure monitoring is very critical in the diagnosis of and management of hypertension. The authors here recommend, and this is just based on their opinions and not based on studies, but recommend that if someone has an office blood pressure in the 130s to 140s systolic, which and are of otherwise normal cardiovascular risk, or if they have a blood pressure higher than 120 and are at high cardiovascular risk, they need out-of-office blood pressure monitoring. They recommend both ambulatory blood pressure monitoring and home blood pressure monitoring, but being a practical pig that I am, I think whichever one works for you and whichever one works for your patient is going to be fine. If somebody has high out-of-office blood pressure, then we want to reassess them aggressively, monitor and modify their risk factors and treat them as needed. So our patient comes back to us with the results of her 24-hour ambulatory blood pressure monitoring, and her average daytime blood pressures are 127 over 91. Her average nighttime blood pressure is 115 over 85. She wonders if she needs to start on a medication. She really would rather not. So what is the cardiovascular prognosis of people with isolated diastolic hypertension? Is isolated diastolic hypertension even a disease? So this was asked and answered in January of 2020. 2 questions. So just what in general is the prevalence of isolated diastolic hypertension now that the definition of blood pressure has changed? And what is the cardiovascular prognosis of folks with isolated diastolic hypertension? So they did a cross-sectional analysis of NHANES data, a longitudinal analysis of ERIC data, and then they validated against 2 other large external cohorts and found that the results were the same. And what they found was this, that obviously when you lower the definition of diastolic hypertension from 90 to 80, the prevalence is going to go up. So the prevalence is now 6.5% of the population instead of 1.37% of the population, as it would have been by JNC7. But the big take home is that there is no difference in incident ASCVD, heart failure, or CKD compared with normotensive controls. Now, most of these big data sets don't include young people, sort of middle-aged and above. So I don't know that this is generalizable to young adults, and young men tend to be the people with isolated diastolic hypertension, and previous studies have shown that that is a precursor of cardiovascular disease. But among this group, just having isolated diastolic hypertension didn't change their cardiovascular risks. Our next patient is an 82-year-old woman with a history of controlled hypertension and diet-controlled diabetes. She's hospitalized for acute diverticulitis. And while inpatient, she was hypertensive, so the hospitalist was trying to do you a favor, and they increased her antihypertensive regimen and told her to follow up with you when she gets home. Since discharge, she notes that her blood pressures have been on the lower side, 103 to 117 systolic. She's feeling fine. She wonders if she should stay on the medications that you prescribed or if she should stay on the medications that the hospitalist prescribed. So the question is she going to do better with a more intensive antihypertensive regimen that she got prescribed in the hospital or not? This was looked at last August in JAMA. A retrospective cohort study. So as we all know, we got to take those with a big grain of salt, but looking at 4,000 hospitalized veterans, I'll draw your attention to the fact that 98% of them were men. And the exposure was whether or not they were discharged with antihypertensive intensification after a non-cardiac hospitalization, looking at hospital readmission, serious adverse events, cardiovascular events, and change in systolic blood pressure. The big take home on this one is that actually not intensifying antihypertensive medications, the patients do better. So within 30 days, the people who had received intensification had higher risk of readmission and a higher risk of serious adverse events, and no difference in cardiovascular events or change in systolic blood pressure. So the conclusion I'm taking from this is when I'm on my hospital medicine rotations, if people are there for non-cardiac conditions and they are otherwise normally well controlled as an outpatient, we need to tolerate some hypertension because trying to intensify those antihypertensive regimens is going to lead to adverse events when they get discharged. She's also irritated because she notices that her feet have gotten really puffy since she got home. And she's had this before when she was on the 10 milligrams of amlodipine. She thinks it's the amlodipine again. And in the past, her other previous doctor had given her furosemide when she swells up. She wonders if she can have some now. So you know that treating calcium channel blocker associated edema with a loop diuretic is not effective, but you wonder, how often is this a thing? Is this something that's happening all the time? This came out in February of this year, looking at how often this sort of prescribing cascade of calcium channel blockers to the loop diuretics happens. It was a population-based cohort study done in Canada over a 5-year period. And the exposure was people who had been dispensed a calcium channel blocker, and they compared them to people who were dispensed any other antihypertensive medication or people who were dispensed any unrelated medication. They excluded people with a history of heart failure and chronic kidney disease to try to kind of get away from the people who actually got their loop diuretic for unrelated reasons. And they were looking at hazard ratios for people who were dispensed the loop diuretic. And what they found is not surprising. People who are dispensed a calcium channel blocker are associated with a significantly higher risk of subsequently being prescribed a loop diuretic that is probably unnecessary. Again, because of the nature of the study design, we don't know why the loop diuretic was prescribed, but they controlled for heart failure and chronic kidney disease. So the take home I'm taking from this is that adults who are prescribed a calcium channel blocker are at risk of being subsequently prescribed an unnecessary loop diuretic, and we need to remind ourselves that actually treating calcium channel blocker associated edema with loop diuretics is not effective. So she comes back to see you a year later. She's 85 now, and her home blood pressures are still in the 120s to 130s. Her diabetes is well controlled. And her adult daughter comes with her and kind of shakes her pill box and says, does my mom need all of these pills? Can we safely deprescribe antihypertensives in elderly patients with reasonable blood pressure control? This is the optimized trial. It came out in May. Looking at the population just like this woman, of about 570 women over the age of 80 who are treated for hypertension. And they looked at medication reduction versus usual care, and the outcome was systolic blood pressure of less than 150 at 12 weeks. Here's a graphic of what I just said out loud. The long and short of it is that there was no difference in the population, in the proportion of people with systolic blood pressures lower than 150 at 12 weeks. So about 86 to 87% in the intervention group and 87 to 88% in the control group. So the adjusted relative risk is basically 1. The quick take on this study is that antihypertensive medication reduction can be achieved without substantial change in blood pressure control in some older patients with hypertension. It doesn't answer whether 150 is the right goal for us, and some of the more recent studies, SPRINT and studies that have come out subsequently might suggest that 150 isn't the target we should be aiming for. But if 150 is our target, we can probably deprescribe safely. And finally, you're seeing a 37-year-old trans woman with hypertension and type 2 diabetes. She read an online forum that her blood pressure medication, chlorthalidone, causes diabetes. And she comes in and says, why the heck are you prescribing me a medication that's making my diabetes worse? So you wonder, what is the impact of a thiazide diuretic on fasting plasma glucose levels? You know that it's a thing, you know that, but you just don't know how much of a thing it is. This was looked at in JGEM this year in March, meta-analysis of randomized controlled trials, 95 studies and almost 77,000 participants. And they compared thiazides with placebo, beta blockers, calcium channel blockers, basically all the other antihypertensives, and the outcome was change in fasting plasma glucose. The take home on this one is that yes, that is a thing. Thiazide diuretics do increase fasting plasma glucose, but it was 0.2 millimoles per liter, which comes out to 3.6 milligrams per deciliter of an increase when it was compared to placebo or other antihypertensives. So yes, thiazide diuretics do have an impact on fasting plasma glucose. I think it's small and probably not that important, especially when we're thinking about whether managing someone's hypertension is more important than 3.6 milligrams deciliter increase in their fasting plasma glucose. So I'm going to switch over to Dr. Golob now. Thanks for listening.
All right, hopefully you can see me and hear me now. Alana, let me know if that's not the case. And we are going to pivot to another very important topic for primary care medicine, which is diabetes, one of my favorite topics. So let's start with the case. This is a 62-year-old woman, history of type 2 diabetes, stage 3 kidney disease, coronary disease, and hypertension who comes in for follow-up. She's currently taking max dose metformin, lisinopril, and atorvastatin, and her recent labs reveal her A1C is 8, GFR 55, and her albumin to creatinine ratio is 100. So the question we pose here is, what is the next most appropriate agent to add to her diabetes regimen to improve her cardiovascular and kidney disease outcomes? And this is a really exciting trial I'm going to talk to you about next, because before this trial came out, we really did not have a better answer other than improve your diabetes control for her. So of course, we're going to be talking about the Credence trial published last summer, and this was the first prospective large randomized trial to look at SGLT2 effect on kidney outcomes in patients with diabetes-related kidney disease. So this trial included 4,400 adults who had type 2 diabetes, A1C range here really broad, 6 to 12, which I love for my cohort of patients, GFR 30 to 90, so that's the stage 2 and 3 kidney disease folks, and all of them had to have urine albumin to creatinine ratio of at least 300, so this is a macroalbuminuric cohort, and they were already receiving max tolerated ACE or ARB. Halfway through the trial enrollment, they started to exclude patients at high risk for amputation based on having seen higher risk for amputation in the Canvas trial. The intervention folks received canagliflozin 100 milligrams a day, and the control was a placebo. And their outcomes, which were stratified by GFR category, included a primary composite renal outcome, which I'll review shortly, and a bunch of secondary outcomes of importance. So what did they find? Well, for that primary composite renal outcome, which included doubling of serum creatinine, dropping GFR to less than 15, needing to start renal replacement therapy or renal death, the hazard ratio was 0.66, which is quite impressive. And the number needed to treat was 22 for 2.6 years to prevent one of those adverse renal outcomes. Also, they did not see an excess in amputations, likely because of changing the enrollment criteria. Also important with the Credence trial is that the benefit that they saw actually extended throughout the range of GFR that was included in the trial. So it wasn't that it was limited to folks with better or worse chronic kidney disease. And that was also true for higher or lower levels of proteinuria. One thing to be aware of with SGLT2s is that because of their mechanism of action, they do cause an initial drop in GFR that's completely reversible when the medicine stopped. And that's because they cause afferent arterial or vasoconstriction, and so they reduce flow through the kidney. But that is important to notice about their mechanism and something to expect when you start these meds for patients. So because of this really positive effect on renal outcomes in patients with diabetic kidney disease, the guidelines have now been updated to recommend that patients with CKD with diabetes should be prioritized to be placed on an SGLT2 to prevent these outcomes. But this gave the makers of SGLT2s something to think about. Could we extend that effect of SGLT2s to patients with chronic kidney disease that is proteinuric who do not have diabetes? So here we're going to talk about the DIAMOND trial, which was published just a couple months ago in June 2020. Here the authors are asking, what are the kidney effects of SGLT2 inhibitors, specifically dapagliflozin, in patients with proteinuric kidney disease who do not have diabetes? This was designed as a double-blind randomized crossover trial. It was very small, just 53 adults who had a GFR above 25 and 24-hour urinary protein excretion of at least 500 milligrams who were already on stable dose ACE or ARB. They excluded anyone with diabetes. They also excluded types of kidney disease that they did not think would be amenable to the mechanism of SGLT2. So that included any type of autoimmune or immune-mediated kidney disease, as well as polycystic kidney disease. And they excluded patients at high risk for amputation, including those with more severe peripheral vascular disease or at risk of volume depletion. I'll also tell you that this population impressively had normal blood pressure at enrollment and normal A1C. So the intervention folks got dapagliflozin, the control got placebo, and this was a crossover, so there was a 6-week washout, and then they switched groups. Okay, so the outcomes again stratified by their GFR. Primarily, they looked at what was the percentage change in proteinuria from baseline, and secondary, they had a bunch of other pre-specified outcomes. What did they find? Well, interestingly, and a little bit surprising, I think, for the authors, when it comes to the main primary outcome, which is change in proteinuria, unfortunately, there was no difference in the SGLT2 arm, which is blue, compared to the placebo arm. However, it's not to say they didn't find any effects, so I'll highlight the ones that were significant. So there was a drop in GFR in the folks getting dapagliflozin as compared to placebo, and again, that's based on the mechanism of action, so we expect that. They also found a significant reduction in weight, and this is presumed to be water weight because these do have a diuretic effect. That was significant. They also found lower blood pressure in the folks getting SGLT2, although it didn't quite meet significant. It was a trend that looked pretty compelling. And so their overall conclusion here is that SGLT2s are having the expected physiologic effect on patients with proteinuric but non-diabetic kidney disease. And the reason perhaps we didn't see more benefit was because this study was just so short and just so small. And so now I get to excitingly tell you about super late breaking news, which is something that gave me a mini MI this morning, which is that the anticipated dappahf trial was published yesterday online in the New England Journal. You guys, you are getting the up-to-the-date information here. I briefly looked at this trial. It is exciting. It was stopped early. I'll tell you a little bit about it. What I was able to study this morning. So this is a much bigger trial, 4,300 patients with both diabetes-related and non-diabetes-related proteinuric kidney disease, stage 2 or 3. The trial again was stopped early, real recently, after 2.4 years. Their primary composite outcome, which is a combination of dropping GFR by 50%, developing end-stage kidney disease, or renal death. The hazard ratio for this composite was 0.61, which was significant. Number needed to treat of 19, and this effect held whether the patients did or did not have diabetes. So I'll let you all study this trial in more detail yourselves as I will do myself, but I think this is encouraging finding for SGLT2s in patients with kidney disease who are not necessarily diabetic. Okay, let's turn back to our patient. She does really well when we give her empagliflozin. As you have a phone follow-up with her, she tells you that, oh goodness, her older sister was recently diagnosed with heart failure and got also put on empagliflozin, even though her sister doesn't have diabetes. So here we're going to talk about another disease for which SGLT2s may have a role, and that is heart failure with reduced ejection fraction. So of course, we're talking about the dappahf trial, which was published last fall in November in the New England Journal. Here, the authors were looking at the efficacy and safety of dapagliflozin in patients with heart failure with reduced EF who did or did not have diabetes. This is a phase 3 randomized blinded placebo-controlled trial enrolling 4,700 adults who had New York Heart Association heart failure classes 2 to 4, all of them EF less than 40%. And they wanted to capture an active heart failure population, so they chose patients who either had an elevated BNP or a recent admission for heart failure within the last year. They excluded patients who are at risk for volume depletion or amputation. The intervention arm received dapagliflozin 10 milligrams. The control was placebo, and their primary outcome was a composite of worsening heart failure or death. What did they find? Well, it was good news for dapagliflozin, which is that for their primary outcome as well as all of the individual components, the folks in blue here, the blue lines getting dapagliflozin did better with concern with need for IV diuresis, hospitalization for heart failure, cardiovascular, and all-cause mortality. And the good news, they did not see excess adverse events for any of the types of events we'd be worried about with SGLT2s. So this is a really positive study, and so far the guidelines have not had a chance to weigh in on this, but I anticipate that heart failure management guidelines will weigh in and start to recommend the addition of SGLT2 for patients with HFrEF. Okay, back to our patient. She's lost 3 pounds since she started empagliflozin, but she's still frustrated about her weight, and she asks what other options are available for her. And of note, she is phobic of needles and is not interested in injectable medications. So what can we now offer her? So here we're going to talk about oral symmegletide, which was, and this trial published last summer in the Lancet, which is the Pioneer 4 trial. And this trial is looking at the efficacy and safety of an oral GLP-1, the first one on the market for us, as compared to subcutaneous GLP-1 and placebo. And just as a reminder here, it has been challenging to formulate an oral GLP-1 because as a peptide, it's hard to get these absorbed across the gastric mucosa, but the makers of this medication were able to formulate it with an absorption agent to help that. So this was, again, a randomized double-blind, double-dummy, active and placebo-controlled phase 3A trial, super fancy, including 770 adults with type 2 diabetes, A1C 7 and 9, on a background of metformin, and they might also be receiving an SGLT2. The intervention folks got oral semaglutide, which was titrated up to a maximum dose of 14 milligrams. As a reminder, you have to take oral semaglutide, sort of like levothyroxine, by itself, no other meds, not much, no food, and only a half glass of water for 30 minutes to allow better absorption. And the control was either injectable liraglutide or placebo in a 2:1 stratification. Their primary outcome was change in A1C, and they also looked at change in weight, and they followed these folks for 52 weeks. What did they find? So in terms of change in A1C, as you'll see, both of the GLP-1s were pretty effective in reduction of A1C by 1.2% at the halfway mark for the oral semaglutide in blue versus 1.1% for injectable liraglutide. At the week 52 mark, there was actually even a statistically significant benefit to oral semaglutide as opposed to injectable liraglutide. And of course, both did much better than placebo. So the winner is oral semaglutide when it comes to A1C lowering. What about weight? Well, very impressively, the oral semaglutide had a 4.4 kilogram loss of weight that was sustained through the year-long trial, performing better, significantly better than both liraglutide and placebo. And this wasn't just due to who kept taking the medicine, because there were similar adherence rates in the trial to both of the GLP-1 arms. So the conclusion here is that oral semaglutide significantly was better than both liraglutide and placebo for A1C lowering and weight reduction. Oral semaglutide was FDA approved in September of last year. All right, so now I'm going to turn our attention to this interesting systematic review and network meta-analysis that was published in June in the Annals. And this was really trying to look at a huge amount of data to give us some insights into choice of anti-diabetic agents for certain populations. So again, this is a systematic review, network meta-analysis, which means fancy math and figures are involved, and hand-waving on my part. But in any case, they identified 453 randomized trials in adults with diabetes where the intervention was given for at least 24 weeks. The intervention was some type of relevant diabetes medicine, and you can see all the classes represented here. And then the control was either a placebo or another type of diabetes medicine. And then they looked at primarily what was the change in A1C from baseline, as well as what was the effect on all-cause mortality. And they had a bunch of pre-specified secondary outcomes. So I'm just going to highlight a few findings for you. The first is that in drug-naive patients, what was the effect of a specific agent on A1C lowering? Well, it turns out for every single agent they looked at, except for a DPP-4, the effectiveness of A1C lowering overlapped with metformin. So that was interesting to me when we think about initial therapy, which, by the way, guideline-based is still metformin. When it came to add-on therapy to a metformin background, there was a clear winner, which is subcutaneous semaglutide had the highest A1C lowering as compared to any other agent when added to metformin, and it even outperformed some insulins, which is interesting. Now, again, the average A1C for the folks in this trial was 8.3, so these are not patients who had really out-of-control diabetes. That being said, certainly the GLP-1s and the insulin combinations had the best A1C lowering when added to metformin. Okay, next, cardiovascular outcomes. So when they looked at all-cause mortality in patients at increased cardiovascular risk on a background of metformin-based therapy, not surprisingly, the agents that you already have heard about in other individual trials did seem to have some cardiovascular benefit, and this is specifically certain GLP-1s and SGLT2s. However, when they looked at all-cause mortality in patients at low cardiovascular risk on metformin, there was really no difference. So it didn't matter in this population at low risk for cardiovascular events which agent you chose. The other thing for you to be aware of is that there were no trials identified looking at high-risk cardiovascular patients who are not already on metformin. So we really don't have any direct data telling us what's the best first thing to choose for diabetes in patients at high cardiovascular risk. And I'm not sure if those trials will be done, but I thought it was interesting. Okay, so I'm going to transition back to Maryann while you can ponder.
Thank you, Dr. Golob, for the very up-to-date, late-breaking news. We're going to have a brief segue into screening and prevention, something very near and dear to my heart. So our first case is a 32-year-old woman who's presenting to established care. She's generally quite healthy. She shares that she's sexually active with multiple partners of all genders and inconsistently uses condoms. You screen her for HIV and other STIs, and her results are negative. What can you offer her to reduce her risk of acquiring HIV, and who should be offered PrEP? Well, USPSTF came out in June of 2019 with a recommendation that all persons at risk for HIV acquisition should be offered pre-exposure prophylaxis. And I can say as a primary care doctor that managing PrEP is a heck of a lot easier than managing AFib and diabetes and coronary artery disease and heart failure and cirrhosis. So I highly recommend that everyone who doesn't already have this kind of in their toolbox, add it to their toolbox. It's really simple and really rewarding. People who are sexually active, who have serodiscordant partners, or inconsistent condom use with partners of whom's HIV status is unknown, or anyone who has an STI within the past 6 months. So that's a pretty big group of people. People who inject drugs, especially if they're sharing their drug injection equipment or they're at risk of STI or sexually acquired HIV, and then anyone who's engaging in transactional sex. And you want to use a once daily oral treatment with tenofovir and emtricitabine. It works, it's pretty safe, it's easy to do, and it saves lives. In August, USPSTF came out with a recommendation that we should be providing behavioral counseling for all sexually active adolescents and adults at increased risk for STIs. This is a pretty big population. We have 20 million cases of STIs a year in the US. That's a lot of STIs going around there. 50% of those cases occur in our young adults. Chlamydia, gonorrhea, and syphilis are all on the rise. And as we know, cases can often be asymptomatic, and there's serious consequences to sexually transmitted infections. So taking a few minutes to counsel our at-risk patients about healthy sexual behaviors is going to save lives and avoid a lot of morbidity and heartache down the line. And then in March, USPSTF came out with their recommendation to screen all adults for Hep C. So previously they had said screen all adults born between 1946 and 1964 for hepatitis C, that baby boom generation, which seemed to be the big cohort with Hep C. They've updated that now to say just screen all adults. Everybody over the age of 18 gets a one-timer. So as we all know, Hep C is the most common chronic bloodborne pathogen in the US. It's the leading cause of complications from chronic liver disease, although I imagine NASH and NAFLD will take over at some point soon. It is associated with more deaths than the top 60 other reportable infectious diseases combined. And we know that cases of acute infection have increased nearly fourfold over the last decade, and that's related to increasing IV drug use and improved surveillance. So, and good news, a safe and effective cure is now available. So every single adult you see who has not been screened for hepatitis C needs to get screened for hepatitis C. And speaking of hepatitis C, a minor detour. You're seeing a 52-year-old patient with chronic Hep C, hypertension, overweight, and tobacco dependence who comes in for a routine visit. They're feeling well. Their medication list is antihypertensive, statin, and aspirin. They read that they might not need to be taking aspirin anymore to prevent a heart attack or stroke. They've never had a heart attack. They've never had a stroke. Does this aspirin need to be there? And you remember that there might be something about aspirin and cancer prevention. There might be something else about aspirin that you want to think about. So what are the long-term effects of low-dose aspirin in people with chronic viral hepatitis? In March of 2020, this study came out in the New England Journal of Medicine that caught my eye, trying to answer this very question about incident hepatocellular carcinoma, liver-related mortality, and GI bleeding in people with chronic viral hepatitis who are on aspirin. It's an observational study. It's done in Sweden. So some of them had Hep B, some of them had Hep C, and some of them used aspirin and some of them didn't. So what they were looking at over time is those outcomes that I've mentioned already. And this was what caught my eye. This seemed like a pretty interesting outcome. The 10-year cumulative incidence of hepatocellular carcinoma in aspirin users was 4%, and in non-aspirin users was 8.3. And the 10-year cumulative incidence of liver-related mortality was 11% in aspirin users and 18% in non-aspirin users. So putting that in math that is meaningful to me, the number needed to treat to prevent one HCC death is 23, and the number needed to treat to prevent one liver-related death is between 14 and 15. So what we saw in this cohort study was that aspirin use was associated with significantly lower sort of liver disease and HCC risk without actually increasing the risk of GI bleeding. So it was not an excess GI bleeding in the aspirin group. And the benefits held regardless of sex or cause of hepatitis or underlying cirrhosis. It was duration dependent, so people who were on aspirin over sort of 3 to 5 years or more had the benefit, and sort of less than 3 years didn't really have the benefit. Obviously, there are some limitations in this being an observational study. We don't know what the viral load, fibrosis stage, whether they had Hep C eradication, their smoking status, and what their aspirin dose was. Sweden tends to be a pretty homogeneous population, so unknown if this same finding will translate into our beautiful melting pot of America. And they didn't include non-viral causes of liver disease, NAFLD, NASH, and alcoholic liver disease. So my quick take on this is that I'd love to see a randomized controlled trial of aspirin for hepatocellular carcinoma and liver-related mortality prevention in people with chronic viral hepatitis, and maybe even throw in there some non-viral hepatitis as well.
Great. So you can hear me and see me again as we turn to another core primary care topic, which is AFib. All right, so let's turn to another case. This is a 70-year-old woman coming to the ED with escalating dyspnea exertion who is diagnosed with an NSTEMI and needs to undergo PCI. She does well with her stenting, but upon discharge planning is concerned about her risk of bleeding as she's already noticed a bit of extra bruising on her apixaban that she takes at baseline for chronic stable AFib. So the question we're going to be addressing now is what is the appropriate antithrombotic therapy for patients with atrial fibrillation who undergo PCI? And so in March in 2020, the Annals published this systematic review and meta-analysis that really tries to combine all the data that's been published in the last many years looking at this exact topic. So here they're looking at what are the effects of dual versus triple therapy on bleeding and ischemic events in patients with AFib who have a stent. The population that they identified were 4 randomized controlled trials. All these names should sound fairly familiar to you at this point: Pioneer AFib, Redual, PCI, Augustus, and Entrust. Overall, about 8,000 patients, where the intervention was dual therapy with DOAC and a P2Y12 inhibitor. And the control arm was triple therapy with vitamin K antagonist, P2Y12 inhibitor, and aspirin. Again, their primary outcome after 1 year follow-up was all-cause mortality, cardiovascular mortality, and also some ischemic events. And the safety outcome is always a bleeding outcome. So when it comes to major and minor bleeding risk, no surprise, DOAC-based dual therapy is clearly favorable and safer. So here I show you the forest plots for major and minor, but important bleeding, and again, clearly favoring DOAC-based dual therapy as safer from a bleeding perspective. But what about when it comes to all these ischemic and cardiovascular outcomes that we're trying to prevent with this antithrombotic therapy? Well, here it's a bit interesting. So as you can see, there's no significant difference in any of these outcomes that I've highlighted here in terms of mortality or MI or stent thrombosis. But it does look as if there's a little bit of a trend in many of these cases toward triple therapy being better for preventing these ischemic events. And that may make sense logically, but here again, we have to sort of compare apples and oranges a bit, which is, would you rather take a bleed versus some kind of an ischemic event, perhaps? Some of the limitations to these is that overall, all of these trials had fairly low ischemic event rates, and so they really weren't powered to tell us if there was an important or meaningful difference in ischemic outcomes that we're interested in. But in any case, the authors concluded that DOAC-based dual therapy is certainly safer than vitamin K-based triple therapy and didn't seem to be inferior in terms of ischemic outcomes. Now, I will let you know that both the American Cardiology Association and European Cardiology Guidelines have both sort of adopted this approach that dual therapy is reasonable after PCI event. And particularly, they say within 1 to 4 weeks, if you choose triple therapy, you could then de-escalate to dual therapy. But I will say there are probably some individuals for whom a more nuanced approach may be needed. In any case, our patient is grateful to take only 2 blood thinning agents, apixaban and clopidogrel, after her stent. She does great after stenting, resumes her active lifestyle, comes in for a year follow-up. We love follow-up in primary care, and says, hey, how long do I need to take this clopidogrel anyway? So now our question is, what is the appropriate antithrombotic therapy for patients with AFib and stable coronary disease? And so now we're going to talk about the AFIRE trial published exactly a year ago in the New England Journal, September 2019. And this was the first large randomized trial looking at this population, which is AFib, stable coronary disease. By the way, this describes a huge amount of my personal patients, so I'm interested. So the question the authors ask is rivaroxaban monotherapy non-inferior to rivaroxaban plus an antiplatelet in patients who have AFib and stable coronary disease? This was designed as a multi-center randomized open-label parallel group trial. It was done in 1 country, which is Japan, including 2,200 Japanese adults who had AFib and angiographically confirmed coronary disease, who had a history of either stenting or CABG, but all the excitement was a year prior to enrollment. The intervention arm received rivaroxaban monotherapy. The control was rivaroxaban versus an antiplatelet, which could either be aspirin or clopidogrel. They looked at a composite of different ischemic and MACE outcomes, and their safety outcome was major bleeding. So what did they find? First, I'm going to show you the unsurprising outcome, which is the safety. So clearly, the folks on rivaroxaban monotherapy as compared to dual therapy with antiplatelet had less bleeding. That makes sense. No problem. The second outcome, which was a little bit unexpected and was the reason why this study was stopped early, by the way, after 18 months, is that the rivaroxaban monotherapy group actually had less of the composite cardiovascular events and all-cause mortality. Again, this was not, I think, expected by the authors and perhaps not totally explained. But I'll dive into a little bit deeper for you here. So when it came to certain components of these outcomes, one thing that does make sense is that there were less hemorrhagic strokes in the patients on rivaroxaban monotherapy. But interestingly, there were both fewer cardiovascular and non-cardiovascular deaths, such as cancer, in the patients only getting rivaroxaban. Again, mechanistically, there's not a clear cause for why that would be. And the authors are a little bit careful not to overstate the importance of that finding. So basically what they do conclude here is that rivaroxaban therapy is safer from a bleeding perspective and at least non-inferior when it comes to mortality and composite cardiovascular outcomes as compared to dual therapy. Again, some limitations. This was one study in one country. It was not blinded, and most of the patients were on aspirin rather than clopidogrel in the combo arm, so maybe that impacted things. Also, the trial was stopped early. But some food for thought, and I can tell you many of my patients would be very pleased to not be taking dual antithrombotic therapy with long-term stable coronary disease and AFib. Okay, let's talk about another important question that comes up often these days in primary care, which is, can our patients' smartwatches diagnose their AFib? So this is an interesting study, the Apple Heart study, which was designed as a sightless pragmatic trial. Basically, Apple owns the data, but Stanford ran the trial and reserved the right to publish the outcome no matter what it showed. Ultimately included 420,000 adults, US adults above the age of 22, all who owned an Apple Watch and an Apple iPhone and who downloaded the Apple Heart app. They tried to exclude patients who had previous diagnosis of AFib or current anticoagulant use. After an e-consent, the smartwatches had an irregular pulse notification algorithm activated. And then if they had an irregular pulse notification, that prompted a telemedicine visit where, again, the study providers try to exclude people with known AFib or unstable patients who are told to go to the ER. If they were stable, they were then mailed an EKG patch monitor, so basically an event monitor to wear for 7 days. What did they find? So over a 117-day study period, about 0.5% of patients had an irregular pulse notification. So not a huge number or percentage of this huge cohort. Of those with the irregular pulse notification, about 450 returned the 7-day event monitor. And of those, 34% were found to have a new diagnosis of AFib. So not insignificant. This was 35% in patch wearers above 65 and 18% in patch wearers less than 40. And another interesting finding is that while they were wearing the patch, the positive predictive value of an irregular pulse notification being concordant with AFib was 84%. So pretty good positive predictive value in this specific group. Again, this would not be the positive predictive value for an irregular pulse notification in this whole population. But for me, this trial gives me some food for thought that when my patient tells me their smartwatch tells them they have an irregular heart rate, I need to pay attention and likely follow it up with a heart monitor, especially depending on their baseline cardiovascular risk. Okay, so now we're going to pivot and talk about DOACs in 2 other venues besides just AFib. And so first we're going to talk about kidney disease and then malignancy-associated VTE. So let's return to our patient. We have great continuity with this patient. She has, remember, as a reminder, the AFib and coronary disease. She's coming back 2 years later, and you notice that her GFR has declined to less than 30 consistently for the past 1.5 years. She's still taking her apixaban and appears to be doing fine. So now the question is it safe, or how safe is it to continue apixaban in patients whose GFR is less than 30? And the background here is that patients with more advanced kidney disease are both at higher risk for AFib and ischemic outcomes, as well as at higher risk for bleeding. So it's been challenging to tease out the relative harms and benefits. So this is a systematic review and meta-analysis published last summer in Annals, trying to look at the randomized data that's been published in this population. Again, they included, they identified 45 randomized trials in patients with CKD3 or more advanced, or who were receiving dialysis. And the intervention in these trials was either a DOAC or a vitamin K antagonist. The control was another oral anticoagulant, aspirin, low molecular weight heparin, placebo, or nothing. And they looked at a variety of ischemic type outcomes, whatever the setting for the trial was. And the safety outcome was always a bleeding outcome. And what did they find? Well, I'm just highlighting here for you the AFib trials that they were able to identify. They found 5 trials that looked at full dose DOAC versus vitamin K antagonist. Of note, very importantly, all of these trials excluded patients with GFR less than 25. And what they found is that when compared to vitamin K antagonist, DOAC did better when it came to preventing ischemic stroke or all-cause death, or hemorrhagic stroke or intracranial hemorrhage. However, when it came to just a composite of major and non-major relevant bleeding, there was no significant difference seen between the DOAC and vitamin K. For all the other indications that they looked at, they actually couldn't find a significant difference between DOAC and vitamin K antagonist. The major take-home point is that when it came to randomized controlled data, none of these trials looked at patients with GFR lower than 25. So we're really in a randomized data-free zone when it comes to this population of patients with more advanced kidney disease. So what does observational data have to tell us so far? Well, this is a meta-analysis of observational data published in the Journal of American College of Cardiology in January, again looking at a similar question. In this case, they're asking, what is the safety and efficacy of oral anticoagulants compared with no anticoagulation in patients with AFib who are on dialysis? So again, a population we really don't know whether it's better to anticoagulate them or not. So this included 16 observational studies, and the intervention was either a DOAC or warfarin, and the control was no anticoagulant. And their outcomes, again, were stroke or systemic thromboembolism, all-cause mortality, and of course, major bleeding. What did they find? Well, when they compared anticoagulant versus no anticoagulant, they were not able to show any of these having a significant benefit in preventing stroke or systemic embolism. Apixaban 5 milligrams trended that way, but it was not significant. When they looked at the effect of anticoagulant on death, this was interesting to me. They actually found that apixaban at full dose 5 milligrams twice a day was associated with less death in patients on dialysis, whereas the lower dose of apixaban and warfarin are not. Again, this is observational data, but it makes you wonder if it's presenting some other type of ischemic event besides stroke. And then the other interesting finding was that what was the effect of the anticoagulant on major bleeding? Well, when it came to apixaban in either dose, there was no difference compared to no anticoagulant and how much bleeding the patients had, which is interesting, suggesting apixaban might be the safest agent, as compared to all the other anticoagulants had a higher risk of bleeding compared to no anticoagulant in patients on dialysis. So a lot of food for thought. What this really tells me is that we are in desperate need for some more randomized data looking at apixaban versus no anticoagulant in patients with more advanced kidney disease. Okay, let's turn to one other DOAC topic. This is a 63-year-old patient of ours coming in for post-ER follow-up. She is getting neoadjuvant chemo for stage 3 breast cancer, and she was diagnosed with a DVT a week ago in the ER, and she was put on dalteparin. Today she tells you these shots are miserable and she's not loving the bruising. Is there anything else we can give her to treat her malignancy-associated DVT? So that is our question, is can we use DOACs rather than low molecular weight heparin, which has been the recent standard of care for treating malignancy-associated VTE? All right, so I want to review briefly this meta-analysis published last December in the Mayo Clinic journal, and this is looking at a review of the previously published 3 high-quality randomized trials in patients with cancer-associated VTE who were on one of the 3 DOACs that had been studied, all comparing it to low molecular weight heparin for 6 to 12 months, all of them looking at what was the risk of a recurrent clot event as compared to safety outcome of bleeding. So what did they find? Well, when they looked at the DOACs in terms of what was their event rate of VTE recurrence, guess what? The DOACs did better than dalteparin in preventing another clotting event. However, when they looked at bleeding, unfortunately, the DOACs actually were worse for bleeding, so the dalteparin appeared safer from a bleeding perspective than the DOACs. The one exception by trend was apixaban, which is this study here, but again, that was the smallest study that was included in this meta-analysis. So that sets the stage for this Caravaggio trial, which was published in March of 2020. And this was the big trial looking at apixaban in this population of patients with cancer-associated DVT. They found 1,100 patients to enroll. They excluded patients with primary brain tumors or brain mets. They randomized them to either apixaban with a high dose for a week and then standard dose versus dalteparin, again, high dose for a month and standard dose. And they looked at, again, recurrences clot versus bleeding. What did they find? Well, it looked like after a 30-day period, the apixaban folks then had less recurrence of clotting. Interestingly, the 30-day mark is when the dalteparin dose went down. So maybe it's just that you need a higher dose of dalteparin. But in any case, that was a positive finding for the trial. When they came to bleeding, they found no difference in major bleeding between the two medications. So again, this is an improvement as compared to the other DOAC trials, which showed more bleeding. So the conclusion here is that apixaban is non-inferior to dalteparin for preventing clotting events, and it had similar rates of bleeding. And this has been taken up with the latest version of ASCO guidelines regarding use of anticoagulants. All right, I'm going to turn it back over.
All right, so rounding the final bend here on our mile-long sprint, we're going to be talking about knees, because you really can't talk about primary care without talking about knees, am I right? Our next patient is a 57-year-old woman with bilateral primary osteoarthritis of the knees. She wants to stay active, but she's just finding that her pain and swelling are getting worse and worse and making it hard for her to want to do anything. She's heard about steroid injections and wonders if it's time to get one. You remember that Dr. Golob mentioned in Grand Rounds 2 years ago that steroid injections might be associated with a decrease in cartilage in the knees, but you're also wondering, like, are we doing these anymore? Should we think about something else? What is the relative benefit of PT versus a steroid injection? This question was asked and answered in April of this year in New England Journal. They took 156 patients who are middle-aged, about half of them women, overweight to obese, with clinical and radiographic osteoarthritis, and they were comparing joint injections to PT. The glucocorticoid joint injection group got about 2 to 3 injections over the course of the year, and the PT group attended about 12 PT sessions over the course of the year. The primary outcome was a WOMAC score at 1 year, and they also measured time needed to complete several physical tests. The results show that the PT group did better. So they had less pain and functional disability at 1 year than the injection group. 18 patients in the injection group ended up going on, had no improvement, and 7 in the PT group had no improvement. And the secondary outcomes all favored PT over injections as well. There are some limitations or things that should give us pause. The PT group had more healthcare visits, and we know that just having a therapeutic alliance with somebody can make you feel better. So seeing a caring practitioner 12 times over the course of the year might be beneficial regardless of whether you do PT or not. 18% of the injection group went on to have PT during the year, and 4% had surgery. 9% of the PT group had injections, so there was quite a bit of crossover. There was a higher proportion of severe OA in the PT group, so that actually makes these results more impressive in a way. But then they also recruited for this study from physical therapy clinics in addition to primary care. So some of the people who were involved in the study were already engaged in PT for knee pain at the time of the study starting. So be that as it may, we should try physical therapy before we start doing other things to people. And her 55-year-old cousin comes in next to discuss her knee pain. She has a chronic partial tear of her left meniscus. It's left her with a sort of pain and clicking and catching sensation when she tries to be active. And she wants surgery. I think it's time. And you wonder, is surgery more effective than PT in patients with degenerative meniscal tears without OA? We know for her cousin, we're going to try PT before we shoot steroids into that joint. Should we try something else for her as well? And this is just a brief one-slide update on this topic from May 2020. And basically, it was looking at the question of whether surgery was better than PT in these meniscal tears. They included 5 randomized control trials in their systematic review and meta-analysis. 4 of them were looking at surgery versus PT, and the other one was looking at real surgery versus sham surgery. And the results were that pain and functional activity were not better in the group that had their partial meniscectomy surgery than for the PT group or the sham operation group. So my quick take home here is that when you have people with these chronic degenerative knee problems, think about physical therapy and functional rehabilitation before you think about doing things like surgery and injections. So that sort of wraps up our whirlwind. We were trying to get it in 50 minutes and it was 54. Sorry, Dr. Crum. Doesn't leave us a ton of time for questions, but we'll stop our screen share now so that folks can see each other and see what questions you have for us. Dr. Golob can come join me.
Yes, that was a phenomenal whirlwind tour of some very high impact articles, and thank you for not bringing up any of the COVID ones. So from a personal thank you from me. There are a couple questions, particularly a couple came up about the article of aspirin in folks with liver disease, and there was wondering of what the proposed mechanism was for prevention of HCC and liver-related mortality, if the authors proposed any sort of mechanism.
They really didn't propose a mechanism. It's unknown to me why this is. And the interesting thing, though, that I was wondering is, like, how do they even do this trial? And in Sweden, low-dose aspirin is prescription and high-dose aspirin is over-the-counter. So, like, you can buy 325 of aspirin at a pharmacy, but if you want to get a 75, you get it as a prescription. And if you want 160, you get it as a prescription. So they're able to track actually who's getting prescription aspirin for, like, preventive purposes. So I thought that was a really interesting thing. It has absolutely nothing to do with your really great question, which is what is the mechanism? I do not know. I'm hoping a very smart hepatologist or oncologist can help me understand what is it about aspirin that is preventive of hepatocellular carcinoma.
And then there was another question on that same vein of, with this study, although it was observational, would you actually change your practice, or are you just more comforted by the fact that there were fewer bleeding outcomes for those patients?
I might actually offer this to my patients with, first of all, I'm going to treat my patients for hepatitis C, or offer to treat them. And thankfully, being at the wonderful VA, that is accessible to all my patients. So do that first. But for someone who has a viral hepatitis, I would talk about, there's sort of small but suggestive data that a little bit of aspirin might help them, and do shared decision making like I do with all of my patients, as you know.
Of course. Excellent. Thank you. And then there were a couple questions for you as well. Do you have any insight on expert opinions on which DOAC to use? The thought has been that apixaban has lower intracranial hemorrhage, but rivaroxaban seems to be used more in these trials. Do you have any comments on that or thoughts?
Alana, can you hear me?
Yeah.
Okay, great. I'm sorry, I missed the first part of your question. Let's take on my headphones. In which population are you thinking of?
Just in general, is just a note that
Yeah.
It seems like rivaroxaban is being used more commonly.
I think honestly, the pragmatic answer is what is covered by your patient's insurance. But my personal opinion is that apixaban is looking more and more like the winner when it comes to safety and efficacy. And so, and there's some thought that the rivaroxaban with the once-a-day dosing is not lasting quite as long as it should be. And so in any case, it's a pain to take a med twice a day. But in terms of safety, it seems to me that apixaban does look more like the winner, especially in these kidney disease populations. And so that's, luckily at the VA, that is easy enough for us to get, but that's kind of my personal favorite at the moment.
Yeah, fantastic. And then a question came up from Dr. Emery of, for our patients with stable CKD, based on recent studies, should we be considering adding a low-dose colchicine for these patients, specifically with the 2019 December article in the New England Journal of Medicine, if you guys have thoughts on that?
Yeah, that's a great question, John. And I actually remember looking at that article, and I honestly don't remember the details, but I remember it wasn't compelling enough to me that I thought it would change my practice and to mention it. And so I hope that I did not look at that too cursorily, but in any case, I'll have to study it again. It did not meet my sniff test, as I recall, for something that I will be doing with my patients, but I'd be interested to hear others' opinions on that.
Okay, wonderful. Well, thank you both so much for such an incredible and comprehensive review with really some excellent take-homes for people in primary care and other venues as well. So I always enjoy. So It was wonderful to see you, although I wish it was in person, but thank you again so much for such a great talk from the both of you. And thank you everyone for joining us here. We had a great turnout today. So
thank you, Dr. Crum, and thank you, Dr. Young, for the invitation. We desperately miss you all and are happy to talk more over email or anything else if people have questions or corrections or other ideas. Let's keep the dialogue going. So thank you so much.
Thank you, everybody.
Take
Take care.
care,
You're heroes.
You're all heroes.
We appreciate
Give yourself
you.
a hug.
Yep. All right. Thank you.